Was I?
2 meters.
Oh, now or before?
Before. You're not meters out.
Sorry. First of all, I will need to express my condolences to all the British people. I was mute and I already did express my sorrow for this loss. It affects all of us. So I don't have any conflict of interest, and that was my first slide. And this is the name of the presentation today: the ugly duckling of the Cinderellas. Why did we choose this awkward name for a presentation or a condition? In this case, sleep apnea. So I will present several cases taken from real medical records and patients that you see every day. They are not atypical at all. This is the first one. This is a young male, my age almost, with several risk factors for cardiovascular disease or many medications, who had a myocardial infarction. Remember, this is the leading cause of death worldwide and the leading cause of male death in the UK. The second case is a 6-year-old girl which has morbid obesity, poor school performance, concentration, and attention deficit in risk. We all have a relative, a friend, a neighbor like this. Many people, it's not atypical. 2/3 of the population are overweight or obese, and 20%, 1 in 5 people, I mean children, age 6-year-old children, are obese. So we have many cases. The third case is a 70-year-old female with chronic atrial fibrillation and knee arthrosis. You have many cases like this. We every day prescribe many monthly requests for like this lady. She came because of that. Many medications, you can see them. The other case is another a young man, a lorry driver who had a single car accident, roll over, and there was no blood alcohol in blood. And remember, this is the leading cause of death in young people and one of the leading causes of death in low-income countries. Another very typical case, you see this every day. Another 45-year-old male with hypertension on many anti-hypertensive drugs and still poorly controlled. We titrate the medication and we give him another appointment in 3 months. More or less following the guidance on that. This is one of them, resistant hypertension. And you can see almost 1 in 5 hypertensive patients, 20% almost, have resistant hypertension. You have seen patients like this today. Another case is a patient with type 2 diabetes, poorly controlled as well, and we prescribe more insulin. Another lady, 71-year-old now, with simple partial seizures, MRI and EEG normal, depressed, dizziness, poor concentration, memory loss, and we increase the antidepressant. Remember that this is the leading cause of death in the UK. 16% of the female died because of dementia. And depression is the leading cause of disability worldwide. So we are talking about a lot of people. Another case, a lady who developed ITA, was asymptomatic when she came to the hospital, and we can see this lacunar infarction on the CT scan. The next case is a 78-year-old man who had a sudden death and a complete AV block, had an implantable cardioverter defibrillator, which is working fine, and we check it and give you an appointment in 6 months. So, and I can show you many more, but I'm not going to bother you all with this. My question is to myself, are there multiple unrelated cases, or all these conditions come from the same origin? So that's why I think about obstructive sleep apnea. When I talk about this, I remember this guy. I think that you remember him. Freddy Krueger. He killed people when they fell asleep. And many of the things that you are going to listen tonight, maybe you never heard before. It's because, as you can see, not very many papers have been published. Only less than 40,000 papers, none before the 80s, and the highest was 3,800 last year. So a condition which is as new as AIDS, for instance, HIV from the 80s, but obviously there are much less information about that. But the first paper ever published was from Charles Dickens, the Pigwig Club. You remember this typical fat guy, cyanotic, sleeping all the time, snoring, which was beautifully described in the book. So what is apnea? Apnea, by definition, is the stoppage of breathing for more than 10 seconds, okay? If you still have breathing effort, it's obstructive because it's blocked the airway. And hypopnea is the reduction of the airflow for at least 10 seconds with oxygen desaturation. This is important, the oxygen desaturation. So what is obstructive sleep apnea? It's a syndrome characterized by the recurrent upper respiratory airway collapse during a sleep that causes apneas and hypopneas with hypoxia and its pathophysiological consequences, which are many. Why do we have this? Why, if we fall asleep, we have apneas or hypopneas? Well, it's because the airway is not rigid. It's mainly muscle, the soft palate, soft tissue. So whenever we sleep, our muscle relaxes and the soft palate does, and it always closes a bit, okay? Normally it doesn't happen anything, but if the airway is already blocked, partially blocked, like here in this case with this tonsillar hypertrophy, like this, it's already blocked. If we fall asleep, the muscle relaxes, close the airway totally, causing apnea, or partially causing hypopnea, snoring. And this is the graphic description of the problem. So it's the blocked airway because of the relaxation of the muscle. So the consequences are hypoxia, hypercapnia, acidosis, which we have obviously acute consequences like myocardial infarction, for instance, arrhythmias, chronic, like chronic heart failure, hypertension, stroke, and consequences related to the frequent arousals. People that fall asleep, have apneas, the brain wakes them up, they survive, but they are the sleep is not steady. They cannot sleep all night long. They never get REM sleep, and they wake up tired the next day. The pathophysiology is very easy. You can understand all this, but it's very complex, obviously, because affects all the systems: the sympathetic system, endothelial dysfunction, systemic inflammation, metabolic dysfunction, and all these here are the consequences of this: stroke, heart failure, diabetes, etc. So, which are the symptoms? Snoring. This is an obvious one. Some people do not snore anymore because they have more apneas, so they don't breathe. They say sometimes, no, I'm better because I'm not snoring. They are getting worse. Daytime sleepiness. Both of these are denied most of the cases by the patient. They don't know that they snore, and they don't feel that they are sleepy. They say that they are only tired, that life is like this, too much work. Hypertension and obesity with witness apneas, all of these 4 or 5 items defines sleep apnea practically, which is the Berlin questionnaire, is a stop bank question. Daytime sleepiness, you know that we can assess through the Epworth questionnaire, but there are many other symptoms: awakening with choking, headache, nocturia, going to the toilet alone, cognitive impairment, amnesia, fatigue, less sexual desire, mood disorder, bad temper, depression, muscle pain, and many other. It affects, as you can see, all over the body and the organ systems. So we can assess the patient holistically. Which are the risk factors? Male, obesity, anatomical deformities, comorbidities, alcohol, smoking, and one very important, hypnotics, because we prescribe it. And I show you several cases before that we have prescribed hypnotics. So these anatomical deformities, for instance, this is the most frequent in children, tonsillar hypertrophy, and this is obviously the treatment is surgical. This micrognathia, the treatment for this is surgical. It is not a CPAP or changing position. And this is obvious, but not all the cases are this obvious, like this lady here. I wouldn't imagine that this needs a maxillomandibular advancement procedure. This is one of the things that we published in that paper, and it's one of the most interesting. Anatomical deformities of the nose do not cause sleep apnea because the nose does not collapse during sleep, which is one of the most common myths in medicine. And you will see many things like this. Please don't use them. And this is the other one. Don't use hypnotics, opioids, or avoid them, anxiolytic, etc., because they are contraindicated in people with untreated sleep apnea. If you treat them with a surgery, with the CPAP or whatever, you can prescribe them, but not before. Comorbidities, Down syndrome, heart failure, stroke, dementia, Parkinson, which are not atypical. We have many cases like this, and this is the most frequent risk factor. Obesity, we have families like this, and you can see in this image that this obese patient, you can see here the fat distribution, the airway is already almost blocked, and he's awake. So, having said all this, here are the consequences, which are the cases that I showed you before. Hypertension, coronary artery disease, heart failure, arrhythmias, cerebrovascular diseases, stroke, diabetes, metabolic syndrome, or obesity, road traffic accidents, occupational accidents, problems with mood, behavior, performance, etc. We know for more than 30 years that sleep apnea is a risk factor for hypertension. You can see the huge difference from these people with sleep apnea with the control. And this is one of the interesting slides in the presentation, because I will show you many papers publishing the results of the studies that it's related or associated with sleep apnea and whatever. But why? We would like to know why there is a reason for this. And this is the biological plausibility: hypoxia, hypercapnia, hemodynamic response, the apneas, repeated arousals, the sympathetic tone increase, the reduced baroreflex sensitivity, the effect of negative intrathoracic pressure, platelet aggregation, plasma fibrinogen, decreased nitric oxide. So it's a machine for hypertension, obesity, diabetes. It's clear the relationship of this, the fourth pandemic of the 21st century. This one, all this. This is one of the important consequences: refractory hypertension. We already told about more than 80% people with resistant hypertension has a sleep apnea, and you remember that he's on 1, 2, 3, 4, 5, 6 anti-hypertensive drugs, and we are only titrating it. We don't need to get there. And actually, I don't wait until they have resistant hypertension. When I see that they have hypertension, whatever the time frame is, I think about sleep apnea. And here, what the guidance said. The right diagnosis of the disease is to eliminate the secondary cause of resistant hypertension, being obstructive sleep apnea, the first. So this author, Pickering, he said, how many of us, when we are first taking a history from a hypertensive patient, ask about sleep habits and snoring? My guess is not many, and I think so. I agree. But there are many papers. It was published a couple of months ago, and you can see that those with refractory hypertension should be screened for sleep apnea. Do we do that all the time? I don't know. And because of all these pathophysiological pathways, not only hypertension, but coronary artery disease is a risk factor. These are meta-analysis, evidence-based medicine. It's not a speculation anymore. 5-fold increased risk of cardiovascular events, coronary cerebrovascular events. And remember the patient with the myocardial infarction, the first one, we prescribe alprazolam, lorazepam. Atrial fibrillation. Not only there is association, but it is a dose-response relationship. Another meta-analysis published a couple of months ago. There is a relation. Actually, more than half of atrial fibrillation patients have sleep apnea. And the lady with atrial fibrillation that we saw, we prescribed tramadol, lorazepam, naproxen, mirtazapine, and zolpidem because of the knee pain and other muscle pain because of not sleeping well. And we prescribe it monthly for years. So this other patient that I presented, it was the pacemaker. And this paper says people with a sleep apnea should be, on a pacemaker should systematically search for sleep apnea, owing the potential detrimental effect on their cardiovascular evolution. Sudden death, a systematic review as well, a meta-analysis published 1 year. And we had this gentleman with the pacemaker, with the sudden death, metabolic syndrome, more than twice. I don't know if you can see, more than twice. Oh, I don't know how to do this. Here. More than twice. 35, 70 will be twice, 87 people with sleep apnea. Diabetes. People with diabetes should be systematically assessed because they can be potentially treatable risk factor in diabetes. And we have many cases like this, obesity, etc. Stroke. If we remember the very well-known risk factor for atrial fibrillation, for a stroke is obesity, race, alcohol, diabetes, atrial fibrillation, dyslipidemia, hypertension. If we see results, the only one of those which is statistically significant is sleep apnea. Well, we are comparing all of them, they are risk factors. We are not comparing against control people, okay? And we had this lady who had the stroke. People who don't sleep well, regardless if it's sleep apnea, insomnia, or whatever, they cannot cope well. They cannot accomplish tasks well. We can, if we're having on a long shift, we cannot accomplish tasks well next day. Our mood will change. Our personal relationship and family and social life is severely affected in people who don't sleep. Sleep apnea, insomnia, whatever. And remember this lady. She was depressed, had dementia. Another paper about the association between Alzheimer's disease and sleep apnea. We, people with sleep apnea, have less gray matter. Here it is. Erectile dysfunction. This is a very interesting paper. It compares sildenafil with the CPAP, and they both work. But it doesn't affect only the patient, the bed partner, because he or she is always waking up the partner, or because of the snoring, the bad temper, or whatever. The partner doesn't have a good quality of life. When the patient is treated, the partner gets better, even hypertension. And you remember this film, she became a monster because she didn't sleep well. And this is the problem with the other, not related to hypoxia, hypercapnia. Arousals are always complicated with hypersomnolence, and the consequences are this, ausentives, presentives, people who go to work and sleep there, and the most dramatic ones, traffic accidents. You remember our case. And we, all of us, fill the DVLA form. This is a professional driver, lorry driver strike. These are the people who drive our lorry here in all over. So, because of all this, we're going to see a lot of patients with sleep apnea, and we didn't know before. So my approach, how to assess it, people with, this is about cardiovascular problems, but people with all these conditions, and the list is longer. I will send you the paper so that that you can read it, the paper that we published last year. So should be assessed with two questions, not to the patient, but the partner, and just seeing them. You can see obesity, you can see the file hypertension, you can check the blood pressure, and you can see hypertension, and you just need to ask them 2 or 3 questions. Does he or she, the partner, snore, the patient? Do they suffer from tiredness, sleepiness? Do they have apneas, witness apneas? If they do, they should be referred to a sleep lab. There are some questionnaires. Edwards sleepiness scale is not diagnosis. It's only to assess prognosis. If you treat a patient, it will help. It will reduce the Edwards questionnaire. But it doesn't mean that whatever the result of the sleepiness scale is, it doesn't say if they have or they don't have a sleep apnea. A stop bank questionnaire is even better than the Berlin one. Cases like this are obvious. You don't need to ask many more questions. They are obvious. They fall asleep in the consultation. But you need to be careful about all these details. You know, the devil is in the details. How do we diagnose sleep apnea? Well, the gold standard method is polysomnography. Many things, many variables are measured during sleep. But because of COVID and many other reasons, because it provides a lot of information that are not always very well understood by the GPs or even the consultants. So we're not doing that anymore. So what we now are doing worldwide is in-home unattended sleep study, which measures variables like oxygen saturation, respiratory effort, airflow, and with this information, we can assess how many apneas and hypopneas per hour, this apnea-hypopnea index, they have. For instance, if they snore once a minute, they have 60 AH1 is 60, and that is obviously very severe case. So if they have an apnea that lasts 30 seconds and they have 60, so they only breathe half of the whole night. During 8 hours, they only breathe 4. They stop breathing 4 hours. So you can imagine how this is. So what is the definition of obstructive sleep apnea? If they have a apnea-hypopnea index above 5 with symptoms, or people who are asymptomatic, but they have more than 15. This is the definition. This is a very interesting slide. This is a sleep test, okay? This in red is the airflow in the measuring the nose and the mouth, okay? And this is the respiratory measuring the chest effort. So you can see that they are moving the chest. There is air coming in and out the lungs. The oxygen is fine, 100%, and the heart rate is steady during all night long. Okay, this is a normal study. 2 minutes here. Okay, but in this case, you can see that the person is they are breathing here. They stop breathing. This marking red. They stop breathing at all. 30 seconds. The oxygen drops 40% from 100 to 60. And the heart rate changes dramatically from 70 to 38, almost twice. This is hypopnea. The person is snoring. There is airflow, but it's reduced, and the oxygen is also low. And you can see all the apneas, hypopneas, low oxygen saturation, and this heart rate, which is the arrhythmia that they develop. After this is 444. Few minutes later, with the CPAP machine, 10 minutes later, this is the CPAP here. All these apneas, hypopnea disappear, and the oxygen goes to normal, and also the heart rate. You can compare this one, sleep apnea, this is CPAP. So the treatment, this is one of them. The first choice is a CPAP device. It's a continuous positive airway pressure. If the problem is that the airway is blocked, the solution is unblock it with, in this case, air pressure. The air comes in, opens the airway, the person can breathe again, and obviously all the consequences are solved. You can see in this image that the airway, which is closed here, with the CPAP opens. The person can breathe. Obviously, if they can breathe again, if they are drowning and they are safe, like here, in this case, all the pathophysiological consequences are changed to normal, and that's why it reduces the risk of coronary artery disease, reduces, but more than half the risk of coronary artery disease. 1 month, you can see the differences, better than treatment. Here is the explanation why, all the changes after the CPAP. Reduces atrial fibrillation. Less recurrence of atrial fibrillation in 1 year. Arrhythmias. The CPAP machine arrhythmias. This is another interesting study. 1 month later, all these variable changes. You can see the left ventricular fraction, more than 15% higher. 25 plus 12. You can see the changes here. 2 weeks. It was when she had sleep untreated, and then after being treated with the CPAP. She was like this, and then like this. Because all the pathophysiological consequences are solved thanks to breathing again. This patient, this is a patient of mine. After 1 month, he was very motivated and happy and did some exercise and diet. After 1 month, this is the other photo. And we can do that. We can motivate, encourage our patients. And it was me before being treated. Obviously, the mortality reduces dramatically by 40%, almost 40% in 10 years. So many people are going to be using CPAPs in the near future, hopefully. But this is not the only treatment. Obviously, there are surgical procedures, and this might be the election for some patients. There are dental appliances. They unblock the airway as well. They could be useful in mild cases that they don't tolerate CPAP. We need to investigate it furthermore, and choose the best one. This is a surgical procedure. Obviously, the CPAP may help, but it's not the solution. And this is in children, obviously. And this is not that obvious as the one that I showed you the first photo, but she would need this maxillomandibular advancement procedure. There are some procedures that were used in the past, but they are no longer done anymore because, and you have seen some patients with this. They had it 20 years, 10 years ago, I don't know. Remember my patient, the one that got better in 1 month. He had one and he didn't get better. So I completely agree with this paper published 20 years ago by Lowe and Wool. They proposed a super pill, many medication in one pill to reduce cardiovascular events by 80%. I agree with this. But if we think about sleep apnea and its treatment, and that would be all. I hope you like my presentation, and I'm ready to answer your questions.